Okay, well, this is it, guys. This is the final video for this course. This is our last chapter of the text that we're going to be covering. And today we're going to be talking about health-related and substance use disorders. So, a little bit of history here as to why we're doing this. The terminology has shifted somewhat. Psychophysiological is the new term for psychosomatic. So what we're really doing, though, still is referring to physical disorders that are caused by or affected by psychological and social factors. Poorly understood physical symptoms can be misattributed to psychological causes. So the reason we need to consider this is that sometimes we think the cause is psychological simply because we don't have a good handle on what's actually happening physically. And remember that we know that the mind and body are connected. And we do the best we can with the information we have. And the we there is the collective we. So physicians, psychologists, teachers, parents, everybody who's involved really does the best they can with what they have. What also can complicate things, of course, is that children are not always the best reporters of symptoms. They are often not very specific and not as clear as we might like them to be. So some of what we're going to talk about is a little bit more on the health side, less on the psychology side, but again, important for us to consider, especially when we consider that some of us, some of you, will be working with children in a health or human service capacity, and it's important to keep these things in mind. So what we're going to start with are the sleep-wake disorders. And the first thing we really need to think about a little bit is, why do we sleep? Other than because, oh, comfy bed, warm blanket, right? So we sleep because that's actually, in the early years, the primary activity of our brain. I remember being pretty shocked when my daughter was a newborn at just how many hours a day she slept, and that was actually what she was supposed to be doing. So she was sleeping somewhere between 18 and 20 hours a day. And that's what newborns are supposed to do. They're supposed to be awake for brief periods to feed and to check out the world around them, but really their job is to sleep. And while they're sleeping, our body does what it needs to do, our brain does what it needs to do. So we need rest. That's our body's chance to restore itself. It's a chance to sort of take care of any unfinished business, and that sort of gets into some of these sleep-wake disorders, particularly when we talk about the parasomnias, which we'll get to in a minute. Okay. Okay, sleep-wake disorders can be caused by psychological problems, or they could be symptoms of psychological problems, and that's part of why we're examining them. We need to sleep, but the amount of sleep we need is going to change with age. And we need sleep to be able to function and for proper development and for restoration, as I was saying before. Okay. In terms of some of the maturational changes, we certainly see that newborns, like I said, they actually say 16 to 17 hours a day, but I would say probably for my daughter and other kids, it was probably closer to 18, sometimes even more. 1-year-olds need about 13 hours a day. Now, as adults, we need about 7 to 8 hours a day. Adolescents tend to need more sleep than they actually get. They tend to need 8 to 10 hours, but they typically are getting closer to that 7 to 8 hour range like adults, but they actually need more sleep. So that's just something to consider. And then in terms of the features of sleep-wake disorders, okay, we talk about dysomnias and we talk about parasomnias. The dysomnias are things that are essentially somewhat negative about our sleep, if you will. So insomnia, so not being able to sleep, hypersomnolence, which is too much sleep, breathing-related sleep disorders, and circadian rhythm sleep disorders. So circadian rhythm is when we have a mismatch, and that often happens with a person's like work environment. So again, people who are shift workers, we're not likely to see that with kids, can often have a circadian rhythm sleep disorder because they work overnights and are supposed to sleep during the day when their body wants to be awake. And so if you look at page 447 in the 6th edition, page 449 in the 7th edition, it's going to show you some of the dysomnias. This is from the 5th edition, so it's a little bit different. You'll see that proto-dysomnia is on here. Just ignore that. We're interested in hypersomnia, breathing-related disorder, circadian sleep disorder. Oh no, sorry, proto-dysomnia we are interested in. We just now call it insomnia. Narcolepsy is something we're really not going to talk all that much about, but it is still in here in the book. Okay, so dysomnias are disorders of initiating or maintaining sleep. And on the other hand, parasomnias are behavioral or physiological events that intrude on ongoing sleep. So things like nightmare disorder, non-REM sleep arousal disorders, sleep terrors, and sleepwalking. And so again, for these, you can look at page 448 in the 6th edition, page 450 in the 7th edition, and you will see this. I'll go back to treatment in a second. So again, we have REM, parasomnia, nightmare disorder, pretty common between the ages of 3 and 8. I can tell you I get woken up at least once a week to, "Mommy, I had a scary dream." When I say what happened, I don't want to talk about it. Okay. So apparently we're doing great on communication in the middle of the night. And then we have our arousal parasomnias, things like sleep terror disorder and sleepwalking disorder, which again, these are a little bit less common, but still somewhat common. Sleep terrors are brutal. One of my nephews had them, and like my brother and sister-in-law, the first time he had one, were like, "Oh my God, what do we do?" And the reality is you do nothing. It's terrifying for the adults and other people around the child experiencing the sleep terror. Children themselves don't typically remember the sleep terror. It's not like a nightmare that wakes them up. So they may look like they're awake, their eyes might be open, they might be screaming, they might be crying, they might be flailing. They don't remember it in the morning, but boy, parents do, because it's terrifying. It's not that it gets less terrifying as they continue, it's just you know what you're dealing with as they continue with it. Okay. Whoops. Okay, so just kidding. Sorry about that. My notes are really off here, guys. So I apologize for that. In terms of treatment for the sleep disorders, the big thing we're going to want to do is really work on having good sleep routines and regular sleep schedules. We talk about a concept with adults known as sleep hygiene, and we can use these same ideas, these same principles with children. We want to establish that their bedroom is for sleeping only. It's not also for playing and doing other things, so that when they go to bed, when they get into their bedroom, they start to associate it with sleep. We want to introduce some sort of nighttime ritual that helps them wind down. We want to limit caffeine late in the day. We might even want to limit food and drink for a couple of hours before bedtime, just so that they're not having to get up to go to the bathroom. And we want to really encourage them that even if they can't sleep, if they can't fall asleep, to still maybe stay in bed and try to relax, teaching them some breathing exercises, things like that. With the parasomnias, what we really want to focus on is just comforting them and also making sure that they stay safe. So sleepwalking is something, my same nephew who had the night terrors also was a sleepwalker. So even once he was at an age where my brother and sister-in-law could have taken the baby gate down from the top of the staircase where the bedrooms were, they left it up so that he couldn't wander down the stairs or fall down the stairs and risk injury while he was sleepwalking. So we think about things like that to help with that. But essentially, we're just going to focus on better sleep behaviors and, of course, for parents to be able to provide some comfort and safety for their children. And here we are at reflection. Question number 1. Do you think sleep disorders belong in the DSM? Why or why not? You've reflected, and so now we're going to move on to elimination disorders. And when we're talking about elimination disorders, we're really talking about two. We're talking about enuresis and encopresis. Enuresis is when children have an involuntary discharge of urine during the day or night, which is a fancy way of saying they wet their pants or wet the bed. The diagnostic criteria are in the text, page 450 in the 6th edition, page 452 in the 7th edition. One of the things that we want to make sure is that the child is at least 5 years old before diagnosing it. So basically, we expect children prior to the age of 5 to occasionally still have accidents. We even expect, again, occasional accidents from children over the age of 5. But this is repeated voiding of urine into the bed or clothes, whether voluntary or intentional. And so it's a frequency of at least twice a week for at least 3 consecutive months, or the presence of clinically significant distress or impairment in social, academic, or other important areas of functioning. Okay, so again, we're not talking about a child who has 1 or 2 accidents and we're rushing out to get them diagnosed and get them treated. But this is a consistent pattern of behavior and it's causing distress or impairment for the child. Okay. Nocturnal only is the most common type, which is when they only pee when they're sleeping, so when they wet the bed. But we also would want to specify if it's nocturnal, diurnal, which means it's during the day, or if it's both nocturnal and diurnal. In terms of the prevalence and course, the rates go down as children get older, which obviously makes sense. For children under the age of 10, we have a prevalence rate of as much as 13%, but then it's less than 1% in adolescents. So again, it's something that we're more likely going to see in younger children. As they get older, it does go away with or without treatment, okay? In terms of causes and treatment, what it basically is that the children don't get the signal that they need to empty their bladder. And so particularly at night, so for that nocturnal enuresis, they're asleep, they're dead to the world, they do not get the signal, their brain does not get the signal from their bladder that they need to void, and so they void in their bed. In terms of diurnal, same thing, they may not get the signal or they may not be paying attention enough to perceive the signal because they're doing other things. So again, it's not something that we can like, hey, snap out of it, you gotta go, but we have to work with kids to retrain them to get the signal and to recognize the signal that they need to go. In terms of treatment, one of the most popular treatments is what's known as the bell and pad method, where you have a pad that goes under the child's sheets in their bed, and as soon as it detects moisture, a bell goes off, it's quite loud, wakes them up so that they can go finish urinating in the bathroom. So the idea is then if they start to make, again, from a strictly classical conditioning, they make that association, the drop of moisture, the bell, it wakes them up, they go to the bathroom, that if they start feeling that moisture coming or that feeling of fullness, that they'll wake up, go to the bathroom and pee. Okay. Okay. Encopresis. Encopresis is the passage of feces in inappropriate places. Yeah, Ian just gave me a look like, really? Yeah, we're going to talk about that too. So again, we'll find the diagnostic criteria in the 6th edition on page 453, 7th on page 455. And really, this tends to be involuntary. So again, we're dealing with a situation where the child may not recognize their signals. They may recognize it too late and they don't get to the bathroom on time, but essentially they are pooping their pants. And again, it's on the regular. It's not just one-offs. So it's the repeated passage of feces in inappropriate places, for example, in clothing on floor, At least one such event occurs each month for at least 3 months, and the child has to be at least 4 years old. Okay? So again, prior to 4, even though children are often potty trained sometime between 2 and 3, we go, yeah, so you had a poo accident. It happens. Once they're older than 4, if it's happening at least once a month for 3 consecutive months, then we start going, okay, what's not working here? Like, what's happening here? Okay? It can be voluntary. Oftentimes, if it's voluntary, then it might be something else at play. So when I worked at overnight camp years ago, we actually had a child who was deliberately pooping on the floor and then smearing the feces on the wall of the bathroom. It only took us about 3 days to figure out who it was and send them home. We were like, clearly you can't be here. You can't be living in a community with 200 other children if you're smearing feces on the wall. It's a health issue, it's a safety issue, and there's clearly a behavioral issue at play, and we're not equipped to deal with that. Okay. In terms of prevalence and course, it's more common in boys. So this is one that is more common in boys, and it's going to decrease with age. So it's about 1% of children will experience encopresis. Causes and treatments. Again, causes, we don't always know. We don't know why the child isn't perceiving the signal. But we know in terms of treatment, we want to, first of all, make sure there's no medical problem going on. So we want to make sure that it's not a case of a child is constipated and not going to the bathroom often enough, so then they don't recognize the signal. If that's the case, we may use something like laxatives. We also want to make sure if we were using laxatives on the child, maybe we don't need to, because maybe that's causing them to go too much and that's why they're not catching it. And then just establishing good bathroom behavior and bathroom habits. So maybe reminding a child to go, reminding a child to wait, looking at what time of day, if they are having these accidents, what time is it happening, how close to meals, and then just establishing this is when you go to the bathroom. And we hope for the best. Okay? Okay, moving on to chronic illness. And a little bit of tea. Okay. So when we're dealing with chronic illness, we're talking about an illness that persists longer than 3 months in a given year, or that requires a period of continuous hospitalization of more than 1 month. So we're not talking about a child who gets colds frequently. We're not talking about a child who maybe gets strep throat 3 times in a school year. We're talking here about an illness that persists longer than 3 months in a given year, or that requires continuous hospitalization of at least a month. So we're talking about much more significant illnesses here. And of course, that's going to have an impact on the child, right, and on their development. I don't think that would be surprising to us. Now, we do know that there are normal variations in children's health. Kids experience pain and illness, right? It's just going to happen. You're going to have kids who get hurt sometimes, who get sick sometimes. Some kids will use illness or pain for some sort of secondary gain, right? So some will embellish or maybe even fake some illness to get out of going to school. I don't know if any of you ever had a test that you didn't study for and you tried to convince your parents you were sick so you could stay home. But by and large, that's not what we're talking about here, of course. What we often see is that girls with emotional disorders and boys with disruptive behavior, they tend to have excessive physical symptoms as well. Okay, and about 20% have some sort of chronic issue. In terms of development and course, children who have chronic illness are more likely than their peers to develop emotional and behavioral adjustment problems. But they still fare better than children with mental health diagnoses. And of course, this shouldn't come as a surprise that children who either are ill for longer than 3 months in a given year or have been in the hospital for at least a month in a given year are going to have some emotional problems and behavioral adjustment problems. Really hard to make friends when you're in the hospital. Really hard to make friends when you're sick all the time, even if you're not in the hospital. If there is some physical disability that accompanies it or an inability to do the things your friends are doing, that is going to be a factor. Also, in terms of behavioral adjustment and emotional problems, I mean, it's hard, right? You're a kid. Kids are supposed to be out there having fun, playing, living their best life. If you're in the hospital, you're not doing that, right? If you're in the hospital, you are also likely subject to testing and uncomfortable procedures and maybe surgeries and maybe isolation, right? So all sorts of things that, of course, are going to take a toll on children. What's interesting, of course, is that even a child who's continuously hospitalized for more than a month is going to do better emotionally and behaviorally than a child with a mental health diagnosis. So that gives us a little bit of perspective as well on the impact of mental health diagnoses on children. In terms of the impact on family members, so I've mentioned before about how families try to stay in homeostasis and how if you have an identified patient with a mental health disorder or certainly with a physical health disorder, it's going to have an impact on the whole family. What can happen is that it can either draw family closer, like everybody rallies around the sick child and everybody is in it together, or it could pull families apart, particularly if parents don't agree on treatment, and also depending on how many other children there may be at home, who else is available in terms of extended family to help out. You may have one parent who feels like they need to be with the child in hospital all the time, and then everything else falls on the other parent, and there's all sorts of issues related to that often. Parents may also experience PTSD-like symptoms if they have a child with chronic illness. Parents often have to watch their child, be with their child during medical procedures. They may see things that traumatize them. I know I was incredibly fortunate that my daughter had to have a procedure done last year where she was under anesthetic, and two other people in my life whose children had had other anesthetic, they had warned me about just how brutal it is to be holding your child's hand and then seeing them lose consciousness. And so I was actually okay. But had they not warned me, I would have been like, oh my God, what is happening here? Because it's terrifying that your child is holding your hand and talking 1 minute and literally the next second they are completely out cold and the nurses are like, you can go now. And they like shooed me out of the opera. And I'm like, what just happened? But I had been warned and I was like, okay. But I could definitely see if parents are with a child undergoing multiple medical procedures, especially if things also may get scary at times, that they can develop PTSD symptoms from it as well. And then in terms of social adjustment and school performance, certainly as I mentioned already, they can have peer relationship problems. It can be hard to make friends. It can be hard to stay engaged with your friends when you're chronically ill. And then school issues because of illness, and they also might miss a lot of school because of their illness. So their illness may make it difficult for them to be in school the whole day or to participate in all aspects of schooling. And of course, certainly if you're hospitalized for a month, you're missing a whole month of school and then some, most likely. So that could be problematic as well. Now, in terms of thinking about how children actually adapt, though, let's not forget that children are really resilient, and children can adapt to a lot of things. I think, again, certainly living in these weird COVID pandemic times, I think a lot of people have been surprised at just how resilient children have been. Kids seem to be having a somewhat easier time with following the rules and the ever-changing regulations about what they can and can't do. It's just like, oh, okay, and it's adults who are lamenting everything, but kids seem to be bouncing back pretty well. We'll see 10, 15 years down the line how this affects their overall development, but for right now, they're being pretty resilient. So how children adapt? Well, one of the things that we have to consider are the parameters of the illness. So is it visible to others? So when we're talking about an invisible illness, something that other people can't see, it's often a lot harder because people say things to you like, well, you don't look like you're sick. Are you sure you can't do that? as opposed to a visible illness, which people often are like, oh my gosh, right? So some of you may have been the kid who came to school with a broken leg or a broken arm, and everybody thought that was so cool and they wanted to sign your cast and all that. But a child with a chronic illness that is invisible isn't going to get that same sort of response, right? They're not cool for having a cast. It's like, well, why can't you do this? So that's going to be an issue. The severity and whether it's life-threatening is also going to be a factor. Of course, if it's really severe, if it is something that's potentially life-threatening, the child is more likely going to have more restrictions. That's, again, going to make it more difficult to adapt. And then as well, the impact on daily life. So a chronic illness that has a minimal impact on daily life is going to certainly be easier for a child to adapt to than something that has a much bigger impact. So a child who maybe at night, because of some sort of breathing disorder, has to be hooked up to a monitor or a machine to help them with breathing at night, like a CPAP machine, that isn't going to affect their life all that much. They just maybe can't go to sleepovers, although right now nobody's going to sleepovers, so it doesn't matter. But it doesn't affect them during the daytime. A child who needs to be on a nasal cannula of oxygen at school, so they have the little cart that they wheel around with their oxygen tank, well, that's going to have much more of an impact and be harder to adapt to, right? We also want to think about the personal characteristics of the child. We know that girls tend to do better with chronic illnesses than boys. They tend to adapt better. Socioeconomic status is going to make a difference in terms of resources available to the family. So again, a family with more means may be able to have more help. They may be able to hire tutors if their child has to miss a significant amount of school. They may be able, it might not be an issue for them to be able to drive their child to and from school rather than taking the bus or having to then be on the adapted transportation. So not the regular school bus, but the special school bus. So those are things that SES are going to have an impact on. As well, from a personal characteristic standpoint, the intellectual capacity and the intelligence of the child themselves. If they can understand what's going on, understand why they're restricted from doing certain things, that's also going to be helpful for them. And then also family adaptation and functioning. So how the family adapts is going to play a part in how the child does. So is the family receiving support? So is the family supportive of the child, but then also is the family getting support? Are extended family members, so like grandparents, aunts and uncles, are friends who are like family, are they supporting the family, able to help out? How is the family impacted by the stress of having a child with chronic illness? So those are going to be factors as well. If the family is really stressed out, they have no support, they're like, the parents are stressed all the time, that's going to have an impact on the child as well. So in terms of some interventions that we can think of, what we really want to do is help empower families. We want to offer things like support groups. We want to enhance the quality of life for the family and the child with the illness. So we really want to make sure that the families are full partners in the healthcare for the child. So it's not just a matter of doctors saying, well, this is what you're going to do, but they're working a little bit more collaboratively. The parents feel like they have a voice. Parents feel like if they have questions, they can ask them and have them be answered and not be looked at like they have 7 heads. And then also things like thinking about, would respite care be something that's helpful? So having someone come in who can care for the child so parents can get a break every now and then if there isn't family around who can help out with that. And same thing, we want to help children cope. We want to provide them with resources, counselors, support groups if need be. We want to also make sure that parents and children have as much accurate information as they can about the illness so that they know sort of what to expect, they know what it might look like down the line, how it might change, because the more information we have, the more knowledge we have, the more empowered we are, and the more supported we felt. So that's really something that we need to be aware of. This is going to take us to reflection questions 2 and 3. So one of the issues that sometimes comes up with chronic illness, particularly in adolescents, is medication compliance. Adolescents don't like feeling like they're different from other people to begin with. Also, depending on the medications that they're taking, there could be side effects. So they might want to stop taking their medication or take it on a different schedule than they're supposed to. So what is one thing that you would tell an adolescent with a chronic illness who is struggling with medication compliance? And question 3 is, why do you think what you tell them would be helpful? So the last thing we're going to talk about is going to be adolescent substance use disorders. And again, I'm really glad that we're going to have the chance to actually talk about this in discussion, because it kind of kills me not to be able to talk more about it with you, especially because of the time I spent as the psychologist at an adolescent inpatient drug and alcohol rehab. Kind of gave me a lot of insight into adolescent substance use disorders. So certainly we will talk about that a little bit more in our discussion, but a couple of things that I want to point out and to keep in mind: that substance use can start as early as elementary school. We don't want to think about that. We want to think about elementary school students as not using substances, but it can certainly start then. And the earlier it starts and the faster a child escalates, the harder it's going to be and the more substances they will likely end up using. So we got to keep that in mind. Substance use disorder cuts across all socioeconomic statuses. We see it in children living in poverty. We see it in children living in mansions. There's no one reason why children or adolescents will start using substances. There are a myriad of reasons. And so that's almost what isn't as important. What's important is, what do we do once they have started using? And what can we do to help prevent them from starting to use substances? Okay. So what we also see happening, particularly in children and adolescents, is that once they start using substances, they need to continue having access to substances. Substances cost money. What do kids not typically have a lot of? Money. So the substance use sort of opens up this Pandora's box of, and now what? Because now they're hooked. And so now they either need to steal, borrow, or start working for their dealer. A lot of times drug dealers will have younger and younger children working for them, either delivering or as lookouts, because they're not going to face serious jail time like an adult would, which obviously is problematic. We see a ton of sexual exploitation of girls and boys, so teenage girls and boys, because they can't afford drugs, so their dealers suggest, well, hey, I know a guy, and the guy happens to be a pimp, and now these children and adolescents are engaged in prostitution. We see theft. We see lying. We see arson sometimes, right? They set fires, sometimes to cover up evidence, or sometimes because someone wants them to for insurance, but who knows? But substance use is a concern in and of itself, but it's also a concern in terms of what happens next. Most of the adolescents that I worked with at rehab were there because they were legally mandated to be there. So they had done something else that got them involved in the criminal justice system. They weren't caught smoking pot and sent to rehab. That's not how that works, right? So they were selling pot, or they were doing something else illegal to get money to buy, whether it was meth or pot or cocaine or whatever they were doing. And then as they were caught up in the criminal justice system, they were given the option, okay, you can go to rehab instead of jail. But our kids knew that if they screwed up in rehab, they weren't going home to mommy and daddy. They were going to jail. They were going to juvenile detention. So it's really a complicated issue. We'll talk more about it in discussion, but I just sort of want to preface it by saying, like, there's a lot of reasons why we need to get this under control, okay? So Diagnostic criteria, page 468, 469 of the 6th edition, page 470, 471 of the 7th edition. And the substance use diagnostic criteria, the same for adults and children. There's no difference there. So again, people are using to a point where it's becoming problematic. It's causing some sort of distress or impairment. Certainly trouble with the legal system would count as impairment. They either develop tolerance or withdrawal. They need more of the substance. They are thinking about the substance, trying to come up with ways to access the substance all the time. There are 10 classes of drugs in the DSM-5: alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, stimulants, tobacco, and other substances. And so what you'll see in looking at this list is there's a mix of things that are legal and things that are illegal or illicit. As I'm about to take a sip of my black tea, yeah, I'm engaging in some caffeine use right now. And it's delicious. But we also probably don't want kids ingesting a lot of caffeine. Alcohol, here in Alberta, we say you have to be 18 to drink alcohol. But we also say you have to be 18 to drink alcohol, not to guzzle alcohol like it's going out of style. We know that adolescents are more likely to binge drink than to drink in a responsible manner. So the legality of the substance has nothing to do with whether somebody is diagnosed with a substance use disorder. So it doesn't matter if it's a substance that is legal or is illegal or is legal at a certain age and illegal at different ages. It's how the substance is being used that is problematic. So I have 2 videos here for you to watch on substance use. One is 30 minutes and the other one is only 7 minutes, but please do watch them because we are going to talk about them in discussion, as well as talking about adolescent substance use in a little more detail as well. And this brings us to your last reflection question of the semester. I feel like this is monumental. What would have been an effective message when you were a teen to dissuade you from engaging in underage drinking, smoking, or illicit drug use? Think on that. I wanted to end this on a real thinky question. And that's it. I'll see you guys for discussion.